Everyone, go ahead and place your name and your campus in the chat. Hopefully everyone is doing well today. Go ahead and place your name and your campus in the chat. Once you have done that, check your name on the screen. Ensure that your first and your last name matches how you are listed on Fortis's roster. I'll give you a minute to place your name and campus in the chat and then go and check and then make that correction if it does not match. First and your last name is very important because remember, these sessions are reviewed by the attendance administrators. If your name is not listed correctly, then you are marked absent. So make sure, let's take time now to check that. A lot of times when we log in, it lists us as our phone name. It may not list us correctly. Even if you're going through a name change, and the name change has not taken place yet on Fortis's system. Listed however it is in Fortis's system. Give you a minute to get that done. Good evening. Good evening. Enough time to make sure that your name is very important, you all. We're taking the time to do this. So you won't remember last week we told you about the attendance policy and how the time adds up. So just make sure that these things are done. And if you're unsure how to change your name, let me know and we will assist you in doing that. All right, welcome to week 2. Hopefully everyone is doing well tonight. I know there have been some issues with Zoom everywhere. Everyone has experienced that. If you were trying to get on Zoom earlier today, in different places, I want to just say it was really massive. It wasn't just one area. It wasn't just us. It was pretty much all over the country, but looks like it has resolved, which is good. So we can go on with our class tonight. All right, so let's look at week 2 here. Let me get it pulled up. So for those of you that could not get on Zoom in your classes earlier today, be sure to check your course room. There was a message from Dean Brown as, she gave guidance as what to do regarding that class that you missed, if you missed the class. If not, but just be sure to check your announcement section. I'm going to share my screen here. And let's look at so if you did miss a class, you will receive further information on what you need to do to make up that class later in this week. So that wasn't a Fortis thing. It was countrywide. All right. And then so week 2. Of course, we do have our quiz tonight. We generally take our quiz at the very first of class when we log in. We're going to just push it a little bit back for this week right here. But just know going forward, once we log in, you will have your quiz when we initially log in and get started. So let's go back. Let me go back to week 1. Because week 1, we mostly spent time with our orientation content. But hopefully you reviewed last week's recording. There was content that I reviewed at the end. Make sure that each week that you're looking back at your classroom recordings. And then, where is it at here? Okay, right here. So week 1, we talked about providing that community care, that was community-based nursing, and that community-oriented nursing. So someone come off mute and just tell me what's the difference with the community-based and the community-oriented nursing.
Community bases outside of like hospital type, I guess.
Okay, then community oriented is what? Community based. One is taking care of the individual, remember, and then the other one is you're looking at the entire community as a whole. We have got to know that. So we're gonna pause here, and then the chat. Let's put. I need to, and then put your responses out so everyone can see it. What is community-based nursing? Not only that, I want you to think about what community-based nursing is, and then give me an example. So I will pause and put a timer on for 3 minutes. Community-based nursing is what we're talking about. I need an example. So think about what community-based nursing is, not community-oriented, but community-based. And then give me an example of what community-based nursing would be. Let me find my little timer here. We'll give you 3 minutes to type it up. And place it out so that everyone can see the example. So I got the timer on. You giving me an example in the chat of what community-based nursing is. Because remember, we do have to know what a concept is, and then we have to be able to apply it. So we're applying it. We have said that one is, and I haven't told you which one, so hopefully you can dig back and think back. What is community-based? One is the whole community, and one is more individualized. And so I've asked for an example of community-based nursing. Okay, let me look at your responses. 1 minute left. 1 minute left. Okay, so 30 seconds, and then I'll give the definition. I want you to look and see your response. Is it correct? 30 seconds. Oh, 30 seconds. Okay. So community-oriented nursing. It is oriented around the community and that population, whether or not it is there's a certain parts of states where people go to retire. So it could be that community of retired individuals. It could be different parts of town. Different groups of people live there. But community oriented nursing, nevertheless, is centered around that community or that population. It's primarily focused on health promotion rather than illness care. So, we have all these people that are retired. This is the community that we're talking about. And so they might not, I'm not saying that they are, but they might not be, thinking about continuing their wellness exams. And so what we would do, our primary focus would be for them we would put on activities and health fairs for them to continue to get those preventative exams and making sure that they're following up with their doctor. So that's as a community or that population. So it's primarily focused on health promotion rather than illness care in that whole group. It's not focused on an individual. So another example would be providing education to families about the importance of vaccines. We know that around September, they start talking about flu vaccines, go ahead and getting your flu vaccine. So that's a whole community. So community-based nursing, it is based in the community, but the focus is on illness care of individuals in that community. So home health care, hospice, schools, occupational health. The illness care is focused on that maintenance. So an example could be you have a person that is newly diagnosed with hypertension, and we're working one-on-one with them, um, trying to understand how to do the blood pressure measurements, looking at that chart and understanding, okay, if you get this reading 120 over 80, this is what this means. If you get 180 over 100, this is what that means. So we're specifically focused on that individual in the illness or that chronic disease that they have, rather than the whole community. So another example of community-based nursing is providing mortality rates to people who may be vaccine hesitant. So we have in the community-oriented nursing, we're focusing, pushing out for people to come get their vaccines done. It's flu season. But then we're giving out flu shots. We can say at the job, you're that occupational nurse. We're giving out flu shots. And that individual might be a little hesitant about whether or not to get the vaccine or not. So the information that we can work one-on-one with that individual with is providing them information about the mortality rates of the people that did receive vaccines and the ones that did not. So we're not for vaccines and we're not against vaccines, but we do provide that information so that they can make a decision. Again, we're working one-on-one with that individual. All right, so let's go to your responses. So look at your responses. Is what you placed in the chat, is it correct? Let's see. Yeah, looks like we're on it. Caring for the new mom after discharge. Yes, you're working one-on-one. All right, so are we clear on the difference, or do I need to go back over that again? One, you're working one-on-one, that's community-based nursing. And then the oriented is broad. Okay. All right. So public health nursing focuses on preventative and not curative services. So you can think about your Alabama ours is Alabama Department of Public Health. Everybody has them in other states. And so they put out these campaigns, like during the summertime. You can see these big billboards about drinking water. So their whole idea was preventing people from getting dehydrated and having those heat illnesses, and so pushing water. You see the commercials, and then even at the health fairs, they were giving you cups and water bottles. They were giving you I call them little shaky things, different things to place in your water, promoting and encouraging people to drink water. So public health nursing focuses on preventative and not curative services. Another thing that we recently that they're pushing is the mammograms. They have this mobile mammography bus. It's a bus, and so they drive around to the different communities. And so their idea is people need to know their status. So like, have you had your mammogram done? If not, hey, come on the bus and get it done, and we come to you. So the focus is on that preventative care, catching it early. All right, so now let's talk about the levels of healthcare prevention. We have 3 levels. I need someone to come off mute and tell me what those 3 levels are. What are those 3 levels?
Primary, secondary, and tertiary.
Secondary and tertiary.
Okay, primary, secondary, and tertiary. Got it. That's good. That's good. All right, and so one, we are preventing. We're trying to prevent something, a problem, injury, illness, injury. We're trying to prevent it from ever happening before it ever occurs. And so, for example, helmet or seatbelt campaigns, kids riding the bike, even adults riding their bikes. We're promoting helmet safety. Kids driving, we're promoting. You can see, like, sometimes when you're traveling, they have like these big flashing billboards. Wear your seatbelt. What does it say? Click it or ticket. And so that's a primary prevention. They're trying to get people to wear their seatbelts. So in the event that something happens, because data shows, yes, there's some that have their seatbelts on and still sustain injuries, but more none than not. Those seatbelt campaigns, immunizations, that is primary. Like I just mentioned, the vaccinations to prevent someone from getting the flu. That's primary. Now, what about someone? All of us have had to get the TB skin test. Was that primary or secondary?
Secondary.
That was secondary
Sec-
because secondary is what? What's
Testing.
what's another word for secondary? Testing,
Screening.
Screening.
screening,
Screening.
screening, testing, detecting, trying to see if. So yeah, so put it into terms so that you can understand. So going back to primary, let's go back again. Primary is preventing whatever it is from ever occurring, whether or not that is pesticide exposure. We can pass out pamphlets. We can do a TV commercial. We can do a radio announcement providing information for workers, particularly maybe migrant workers, whomever that deals with pesticides, so that they will lessen the chance of them being exposed to those pesticides. We can do a one-on-one conversation with someone, but we can even teach how to put on your PPE. That is preventing from something from happening. Okay. So then secondary, I just said it was testing, detecting, trying to determine. We are screening, trying to see for early detection. Just like when I mentioned about we were talking about community-based and community-oriented nursing. One is focused on the care of the individual. That's community-based nursing. And so when that mobile or that little bus that goes around to do the mammograms, what level of prevention is that?
Secondary.
Secondary. Now, once a person has been diagnosed with a breast abnormality and they get those follow-up mammograms, now that mammogram is what level of prevention?
Tertiary.
Tertiary, because there is something there. All right, so secondary, we're screening, we're testing, we are trying to determine if there is something there. Early detection, because we want to prevent complications. So we're screening, we're testing. What about if we are at the health fair and we actually did it the other weekend. They had this huge health fair. They had dentists on site. They had doctors on site. Nursing students was there. And the nursing students were asked to do blood pressure screenings. What level of prevention was that?
Secondary.
Secondary. They were testing people or screening people or measuring blood pressures to detect whether or not that blood pressure was elevated. So that's an example. So we're screening individuals, just like we said that TB skin test. We're being screened to see if we have been in contact with that bacterium. So if it reacts, then that means that we have been in contact with it. So the mammograms initially, that is a secondary level. Okay. So now let's go on to tertiary treatment. It is where there is something has already occurred, whether or not it's an injury, that person has a broken bone, that person has a back injury, that person has diabetes, they have something there already. And so the intervention at that time during tertiary, we are trying to help or assist that person manage that disease process. Or with that broken bone, that bone heals. So there is something there. Management of a disease to decrease the symptoms and improve that person's quality of life. Medications, it could be meds, it could be non-pharmacological with tertiary. For example, with the back injury, that person can go in for physical therapy. And then once they discharge from seeing physical therapy, they may be given some exercises that they can do at home. Those interventions, those exercises that they will do at home will be tertiary because they're trying to manage or improve their quality of life. in reference to their back pain. So we have medications, even if that person has, let's see, a different one. A person has hypertension and they are asked to consume a low sodium diet. That is tertiary because that person has something, that a disease process called hypertension. When we're asking a diabetic to check their glucose, do those finger sticks, that is tertiary because they have diabetes. Weight loss for someone, even if weight loss, this is a good example of non-pharmacologic. Someone has been asked to, lose weight, lose a few pounds, that will assist with their hypertension or their diabetes. So that's an example of tertiary level of treatment because they have that chronic disease process. Okay. Are there any questions about the different levels of prevention? Different levels of prevention. So make sure that you know the definition, but then also you're able to give an example. You have to be able to give an example. And we'll go back over it some more, but I want you to understand we need to be able to apply what we know about the concept. All right, so let me hear from you again. Healthy People 2030. What is the Healthy People 2030 campaign? We're almost ready to do Healthy People 2040, but right now we're still on 2030. Someone come off me. I need to hear from 3 people. Tell me, what is this Healthy People 2030 campaign all about?
It's goals for the community to reach in order to have better health.
Okay. 2 more. What is the primary goal? So think about that. So what is that primary goal of Healthy People 2030?
To promote health.
Promote health.
Improve health and well-being.
Health and well-being. Okay, good. So one of the primary goals of Healthy People 2030 is to achieve health equity, eliminate disparities altogether. That's really their goal. And improve health and well-being of all groups, everyone. And so they really want to eliminate any disease processes. And if someone does have like DNA genetic disposition to end up with a disease process, that is gotten early, it's detected early. And so that's why an exam that comes to mind is the colonoscopy. And so I want to say, was it maybe like 5 years ago? I think it was 5 years ago. I know it wasn't longer than that. Initially, it was pushed. Get your colonoscopy at, was it 55 or 50? 55 or 50, one of those ages. But because the healthy people were collecting, as a whole collective, were collecting information. They collect information when people die. They collect information when certain disease processes are reported. And as a result of that, they said, hey, we need to lower the age of people of the recommendation where people are getting these colonoscopies done. Because what we're finding is people are dying at a mortality rate at a large rate at this age. So what did they do? The data supported, the evidence supported. They lowered the age of colonoscopy screenings. So I think now it's 45. I'm almost sure it's 45. And so as a result of that, healthy people gathering all this data, they submit changes to the insurance company. So now when someone turns 45, it is one of those covered screenings because they found out, hey, if we can catch this disease process early, if we screen secondary prevention, if we go ahead and get them in, and if we find a abnormality there, it is the quality of life and the recovery of it is so much better. Because right now what we're doing, we're seeing all of these people dying, and we should have caught this earlier. So again, one of the primary goals of the Healthy People 2030 is to achieve health equity, to eliminate disparities, and improve the health and well-being of everyone, all. Another one that is discussed in your content is reducing firearm related deaths. So gun violence is a risk factor for accidental injury or death among children. So when we go in to evaluate the client's home for safety, we're not for firearms and we're not against them. But once we go in and the family say, discloses that they have that, it's priority that we as the nurse do what about that firearm? What do we need to find out? What's priority?
Is it accessible
Okay.
to like kids?
Okay. What else? So let's do our list. So is it accessible to children? So when we are the nurse, we're evaluating, we're doing a home visit. We are evaluating the client's home for safety that has a firearm. What are some things that we need to consider when we are evaluating that home for safety? What did you just say? Repeat what you just said.
Is the weapon like accessible to children?
Is it accessible? So where is it stored? Is it can someone easily get to or have access to that firearm? What else?
Maybe is it loaded?
Okay. Is it loaded? Where is the ammunition at? And if it's not loaded, where is the ammunition? Are they stored separately? Is the firearm and the ammunition stored in a separate device?
Check for safety. They don't have rope, the hallways, the flooring, that they don't have any accidents, like lighting, they have stairs where they can see.
Okay, so the whole point of the reason that they might have the firearm is for safety in the home. So in case there's an intruder. So we want to make sure that they should have night lights so that they won't mistakenly think that it's an intruder and it's really a family member. Okay. So another thing that comes to mind, have they been trained on how to use the firearm? Okay, so all of these things are discussions and information that we should be discussing if we're going to do that home safety check. But the priority out of our list, the number one is to find out where those firearms are actually stored. So we talked about the firearms, we talked about the ammunition, we talked about the safety in the home, making sure things are well lit. The ammunition is stored in a separate place, and have they had training? From our list, the priority is finding out where are those firearms stored. Okay. Let me go back to Healthy People 2030. So true or false? Is Healthy People 2030 a framework for some Americans? Is that true or false?
False.
Okay. What would make that statement true?
For all Americans?
Okay. Got it. Good, good. All right. Any questions so far? Let me check my chat to see if there are any questions before we move on. Okay, hearing none. All right. So let's talk about what is uninsured, and underinsured. What is the difference between that? Uninsured and underinsured.
Uninsured would be the majority of people that don't have it, and then for underinsured would be people that can't get the treatment that they need due to their insurance not covering it.
Exactly. And the underinsured, these people, these individuals have insurance. We might be those individuals as we move forward in this journey, because what we're seeing now is some insurances are not paying for because initially, like if people went through testing and they've shown the traditional route that those medicines, that dose doesn't work for them, then what is that thing called? It's they complete what you all help me out. What's that thing that they complete? It's some extra paperwork that says, hey, what is it?
Prior authorization.
Prior prior authorization, a PA. And so usually, once they fill out that paperwork and, they can get approved for whatever. But what we're seeing now is that more and more that the insurance companies are not covering life-saving day-to-day treatments and medications. So more and more are finding out that they're underinsured. And so we'll talk about this more with the Affordable Care Act. It's a marketplace so that people can go in and look at each plan and pick out which plan best suited you. Because if you have a certain chronic disease, it's going to be known that you're supposed to have, in order to maintain and manage that chronic disease, you're going to need a certain amount of lab draws. You're going to need a certain amount of MRIs and different type tests. So with the marketplace, the Affordable Care Act was made insurance affordable and more accessible. So it was not just a one size fit all. So if you know that you need a certain amount of tests and follow-up done, a certain amount of doctor's visits, that you can go in and select that plan that match your need. But what we're seeing now is insurance companies are changing the amount of coverage that they initially provided. So in the event that someone is underinsured or does not have insurance at all, those preventative exams, going in to get your teeth cleaned and checked every however many months it is, going in and getting your mammograms done, those screening mammograms, going in and just getting your well check done. If you go in and you're underinsured and it's not covered on your insurance, or if you are uninsured, guess what happens before you pass the front desk? You have to go into your pocket and swipe, tap, or either write out a check or something before you can go forward. And if not, sometimes they will bill you. But then the price of that exam, it's really high. It's really high. So as a result of that, what do you think people do that are underinsured or uninsured in reference to going ahead and getting those exams done? What do you think they do with those preventative exams?
They don't.
They don't. They don't. I mean, I can just remember like, oh, this costs this, and I need gas in the car. I need food. Okay, well, I'm just gonna wait on this. I'll call you back and reschedule. You don't. So as a result of that, so knowing that, we know what uninsured is and underinsured is, and we know like the consequences of that. So we just said they more than likely will not go and get those preventative. They're more likely to not get those preventative wellness exams and tests done. So with that being said, is this true or false? Those individuals are less likely to be diagnosed with advanced disease.
True.
False.
We have a true and a false. So we have two false. So let me reword it just to make sure that what I'm saying is clear. So we've just said uninsured. That's a person that does not have any insurance. Underinsured is they have insurance, but it's just not enough to cover the tests and all the things that's recommended. And so they can move forward. Both individuals can move forward with getting these tests and these preventative exams done, but they just have to come out of their pocket. They have to actually pay for it themselves outright. The original price. They don't get the insurance price. So a well visit might be $200. And so we said as a result of that, more than likely these individuals will not get those exams done. So my question to you now is what you know, all that was true, what you said. So I need you to apply what you know. Is this true or false? A person that is uninsured, no insurance, or underinsured, they are less likely to be diagnosed with advanced disease.
It's true because they're not going to the doctor as often. So by the time they go, it's already advanced.
Okay.
Yeah.
So you
More
said
likely.
both in your example, but they are more likely. So you gave, so let me clear it up. Let me just make the statement. So that statement it is false because they're more likely to be diagnosed with advanced disease because they're not going. So think about the reason that we're going to get checked up is so to make sure that there's nothing there. We're going to get screened. So when they do decide to go, or if they go, or something happens to them where they have to go to the emergency room, they are more likely to be diagnosed with advanced disease. They're not going to be caught early. Because remember, the reason for going to get these preventative exams is to catch it early. And so they are more likely to be diagnosed with advanced disease. Okay. Are we clear on that? So then where were they more than likely is a person is underinsured or uninsured, where they're more likely to go get there if they have to go to the doctor in something they just can't put it off. Where they're more
Hospital.
likely
Hospital.
setting, the hospital setting, because they're not going to turn them away. They may come in and say, hey, we need you to do, sign this paperwork, but they don't turn you away. So they just go on and that individual is taken care of. So they are more likely to be diagnosed with an advanced disease because they haven't been going to get those preventative exams. They're more likely because they haven't been going to get screened. Okay. I know that one gets kind of thick there, but yeah, so once they're actually diagnosed, they're usually well advanced because it has not been caught early. All right. So body mass index, what's two measurements are needed to calculate the body mass index? And what is this body mass index anyways?
Height and
Height and weight.
Height and weight. And then it puts us into a category. It says whether or not we're underweight, whether or not we're overweight, obese, or right on target. And so going back to the Department of Public Health, one of those campaigns that they've been doing here lately is in asking people to get up and move, physical activity. They've been promoting that because the chances of us being just sitting and not moving has just increased. I think it's maybe technology. I don't know. It could be the weather because look, when this year came in, it was one state I was looking at. It was like one weather event after the other. So what are these people doing? They're at home. They're not out and about walking. They're not visiting gyms because they had floods. They couldn't even leave their home. So then they're sedentary. So as a result of that, if you are a child and you are in that 90th percentile, well, really above the 70th percentile and on up, you're considered as obese. So with us knowing the two measurements that are needed to calculate the body mass index, we just said that the body mass index tells us, hey, you're right on point, you're right on target for your weight and your height, or you're over or you're under. With that being said, if a person has a 80 or 90% BMI, if they fall in that category, are they getting enough physical activity? I see heads going left to right. So they're saying, you all are saying no. Okay. So as a result of that, what would be your intervention for that person?
maybe recommending low impact exercises that they could do.
Okay. All right. What else? What else would be another intervention? So we know what we've identified what body mass index is. We've got those two measurements. The person they place you in a category. One says you're underweight, you're right on weight, and the other one says you're over. So a 90th or 80th percentile means that you're overweight. So with us knowing that, what is our intervention what's another intervention that we can recommend?
Diet modification.
Okay. Changes in your diet. What else? One more.
If you get them connected with a dietitian so they can get educated on how to be more healthy.
Okay. Making different food options, selections. Good. So getting up and moving, trying to get a nice balance between the consumption of calories and that moving part. So then that person can come back more toward that healthy weight, that healthy body mass index. So again, we're taking what we know and then we're applying it to a situation. So a person that has a 90th percentile or 80th percentile, they're overweight. So would this be an intervention that we would prescribe for them to eat more meals or snacks throughout the day?
No.
Okay. So what word made that intervention that we would not select for someone that would be in the 80th or 90th percentile?
Okay.
What was that?
More?
More, exactly. So test taking tip. Watch those little words. Now, if our person, now let me change it up. Now we're not talking about body mass index. If we had a person that, well, we can talk about body mass index, someone that was underweight, would that be an appropriate intervention for them? More
Yeah.
frequent meals or snacks throughout the day. Exactly. So good. You all did good with that one. Okay. So a person that's overweight, we want to get them to get up and move, physical activity. We want them to have a nice balance between the calories that they're consuming and then that physical activity. So we can encourage them to join the gym, to take a walk around the yard. And if there is, even if they have a job where they're not up and moving, we can encourage them to just get up and move during their breaks. If it's a child and they're not active in any sports, we can encourage the parents to some type of way decrease that overall screen time or that amount of time that they're not moving around. Okay. So what about those 100% fruit juices? Are they any good or are they not recommended? Kind of tricky with that 100% fruit juices. So 100, are they
Not
are they recommended?
not.
No,
No.
because they have those empty calories. So don't be tricked by that when it says that 100 fruit juice or 100%. So usually those have those empty calories. So those are not recommended. Those are not recommended. Okay. All right. Any questions so far about the concepts that we have covered? So iron deficiency is something usually children, usually young adults, are usually detected pretty early on. So what are some food choices that are recommended for someone that has iron deficiency anemia? What's some few food choices that we would recommend?
Beans, spinach, liver.
Okay, I heard beans, spinach, liver. Did someone say eggs?
Kale.
Kale and eggs. Okay. So yes, we do want to encourage them to consume those food items to get that iron level up. Eggs is one that's been in the news, so everyone's familiar with that, but it does help with that iron deficiency anemia. So we are that school nurse. And when you're that school nurse, you wear so many different hats. Everyone comes to you, the children, the adults, the parents, they come. So you're the school nurse and you're doing blood pressure screenings. You're doing just screenings overall. And we have a child that comes to you and they ask a question about some type of discoloration on their skin. They ask you to check their blood pressure. You don't have it diagnosed. You don't have it on your files. You don't have your care plan or any information from the doctor, the parents, saying this child has high blood pressure or diabetes or any disease process. But based on your head to toe assessment findings, you are pretty much sure that after doing that blood pressure screening, after looking at the skin, particularly maybe the discolorations on the neck crease or either the armpits, you're doing that blood pressure screening and that blood pressure is over the recommended allowance. And pretty much you're pretty much thinking this child probably has diabetes or high blood pressure or on their way. Do we tell or diagnose that child and tell that parent or that child, well, I think you have diabetes. I think that you have high blood pressure.
No.
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 Okay. So what we advise those parents for their child to do?
Follow
Follow up
the
with their primary.
primary or the specialist.
Follow up, go and get that medical evaluation done. So we want them to follow up. So remember, we don't diagnose. So, and if we don't have that information on file, then we advise them to follow up to get that full medical evaluation done. Okay. So we talked about, I kind of mentioned, no, I didn't mention lead poisoning. But lead poisoning is where, and it's harmful. Lead is harmful to the human. And so initially we didn't know that. So prior to, what year was it? I can't remember the year. Lead was pretty much in everything. Gas, it was in paints. It was just a good, I think, preservative it was a good additive to make things do what they needed to do. But we found out from the evidence, well, this people being exposed to this lead is causing developmental delays, and so finding that out, they pulled lead out of everything. Now your gas is unleaded. Now the paint doesn't have lead in it, and lead is just not added into things. But initially what they did was they did lead levels. Everybody that came in to get their well checks, because they knew lead was in everything, was in paint, was everywhere. So they drew blood. But once we found out that lead was harmful, they pulled it out of these things. They pulled it out of the paint, the gas, and all these different things that we use or that we come in contact day to day. So going forward, with that being said, now especially the children, when they come in, they will do a questionnaire for the parents, and they'll ask these questions to screen, to detect, to determine whether or not if there is possible lead in the environment. And then depends on the answers to those questions, and of course depending on the assessment of that child, especially if they're experiencing developmental delays, then they'll do that lead level to verify, hey, this is connected to your child being exposed to lead. But you do want to evaluate that environment. And they do ask those questions now. And then they have some type of, I want to say they're lead certified. I can't remember the other part, but they're people that know how to go in and do whatever to make that environment safe. But we do want to evaluate that environment, ask those questions, especially if we're seeing, developmental delays with the children. And if their homes were built before, I'm going to get the dates for you. I think it's in 1970 or 1950 or somewhere along up in there. They're for sure are going to do those lead levels, because more than likely there is paint lead is in whatever was used to build that home with. So that child or those people are exposed to that lead. And like I said, it is harmful to the human body. All right. So when we are trying to take care of our patients, we're still that school nurse. We're going to take care of all of our students. But initially, what guides us is to who to take care of first. Because they'll come to you for everything. They'll call you to the gym. They'll call you to the PE field. They have injuries. They have this going on. But who are we going to take? We have 3 students lined up. What helps us to decide which child to take care of first?
ABC.
Symptoms.
ABC. All right. So, but usually though, think about it. We're talking about children. They can't tell us that they're short of breath or having trouble breathing. So we're applying what we know. Who we're going to take care of first? We said ABCs, airway, breathing, circulation. So what are those things that we might assess that will equal that this child is having problems moving air with airway, breathing, and circulation? What are some things that we might see?
Cyanosis.
Mm-hmm.
Nasal flare.
Okay. What else?
Deep, shallow breathing, maybe.
Okay.
Hunched over, trying to get in a position to breathe.
Mm-hmm. So the rest of the students are out there running, jumping, and hopping, and this child is, they're not participating in whatever it is, the physical activity that is going on. They're coughing. They're unable to complete sentences. They're trying to talk to you and tell you something, but they're just trying to catch their breath. So again, another example of taking what we know and applying it. So we do have, what does the word vulnerable mean?
At risk for certain things.
Okay. Someone else, what does vulnerable mean? Hello. What does vulnerable mean? If someone is vulnerable for something happening to them, do they have an increased risk for something not so favorable happening, or do they have a decreased risk?
Increase.
Increased.
Increased risk.
Increased risk. So what comes to mind is, remember last year, was it last year? Maybe 2 years ago now, where diabetics they were a vulnerable population. Why were they a vulnerable population? I know no more than 2 years ago. What was going on?
The insulin, was it about the insulin?
Shortage of insulin.
There's Ozempic.
The Ozempic, the what do they call them? The SGLs, the medications that were prescribed for someone that has diabetes to control their diabetes. It was also found, evidence was collected, and it was found out that that same medication could be used for weight loss. And as a result of that, the clients or patients or people that there were more people using it for weight loss than can be made for the people that needed it for diabetes. So as a result of that, people that were diabetic and were prescribed the different medications, they couldn't get it. So it put them at risk for not being able to manage their diabetes. They had an increased vulnerability because of that. But doctors were resilient. They were like, okay, well, wait a minute. There are other medications out here. What else can we prescribe? As a matter of fact, the other day I was talking to a young lady, and that's exactly what happened. The medication that she was originally prescribed and she was doing well with, she couldn't get it. It was just not available because there were other people getting the medication, more than likely for weight loss, which was fine because there are medications out there that were made and designed for one reason, but once the scientists went back and looked at it, they realized that, well, this medication can also be given for this. It can also be given for that. But so what did her doctor do? They didn't just let her diabetes get out of control. They found out what else could she be prescribed. And of course, they found it out. And so she's being managed with a different medication. But vulnerable populations generally are those that have some type of chronic disease process, whether or not it's diabetes, hypertension, it could be HIV. And then those that are young, because think about it. If you are under 19, under 19, you solely rely on someone else taking care of you. Even though you might can get a job at 15 now, you can get a job at 16, but still, you really do solely rely on someone else taking care of you. So a person that's a substance abuser, because think about it, if they're using substance, they're not making rational decisions. They're thinking about that, that getting that substance that's harmful to them. And then also our veterans, they're also considered vulnerable populations. So a person that resiliency is that ability to bounce back, and so a person that's resilient actually have a decrease. They're less vulnerable because what they do, just like the example that I just gave about the young lady, not being able to get the medication. The doctor just didn't stop there. He kind of pivoted. Well, what else is out there that we can help you manage your diabetes? And it may manage it better. And so resiliency reduces or decreases our person's vulnerability. So they're less likely for something bad happening to them or them having not so favorable results. So being resilient decreases or reduces that. Okay, are there any questions about the content that we went over thus far? All right, so we are going to pause. Break at the end here. All right, so
Professor, when we finish, can you explain? Because I think that I do it well, but I saw that my note is like a 1 point and something, but I want to know if in which one I have make a mistake.
Okay. Community-oriented nursing. You're welcome. It's the whole population. It's that community. The example that I gave you all was the retired individual. So that would be a community of individuals that we're focusing on them still getting their wellness exams or whatever it is. But community-based nursing is you working on one-on-one with an individual, and it's about illness care. And so which one would be working one-on-one about illness care? Would it be someone we're talking to them about their newly diagnosed hypertension, how to use that monitor so they can measure their blood pressure? Would it be a person that is newly diagnosed diabetic and they're trying to figure out their glucoses, what to do? Is it a person that has asthma and they have an inhaler? Or is it we're doing a community health fair and we have a table set up and we're focused on sun exposure for that community? Which of those are examples of community based nursing?
Well, in the test, in the quiz,
based on what I just said, based on what I just said, I
you-
want you. Community-based nursing is focusing on that individual. Community-oriented is that whole community. Of the examples that I just gave, which one matches that definition? I gave you 4 examples, or select all that apply. We have a person that's newly diagnosed hypertension. We're talking to them about measuring their blood pressure. We have a diabetic. We're talking to them about measuring their glucoses. We have someone that has asthma and they have a new inhaler. Or we have a booth set up at the community health fair, which is select all that apply based on what you know that community-based nursing is illness care of an individual. Which people, you all? Are the examples that I just gave?
The diabetic, the asthmatic, and the blood pressure for the
Asthmatic,
hypertension.
the new inhaler.
Okay, got it. So we
That
can't
one.
speak that it is individualized. So any example that you see that we're working one-on-one with someone and we're trying to teach them something about their illness, we're trying to get them to manage their illness. That's community-based. You got that? Is that a little bit more clearer? So out of those 4 examples that I gave, 3 of them were community-based because we were working with one-on-one with that individual. Community-oriented, we work with the whole community. So that example, I think that was there was, because we still have people that haven't taken the quiz yet, was a group of people. So that would eliminate it being working one-on-one. Okay. So that's how you can narrow it down. One is one-on-one and the other one is not. One is a huge population. One is more than one person or several people. And the other one is, and that's just pretty much community oriented, also is primary prevention. Community based, it is tertiary. That's another way of looking at it. That may help you all narrow it down, be able to tell the difference between. Okay, you got that. So no matter how you see it, you know, one is illness care. Tertiary, we're talking to them about how to manage something. That something is a chronic disease process. It could be an injury. They could have had a broken arm. All right, so that was that one. I think y'all know which one I was talking about. Let's see here. Healthy People 2030. Is it for some or all? All Americans. And so all Americans. And so it is that framework that improves the health of all Americans. So uninsured and underinsured. Are those persons going to get their preventative exams when they're supposed to? More than likely, no. More than likely, no, because they have to come out of pocket. So make the connections with what uninsured and underinsured mean. So with that being said, if they even get diagnosed with something, they're going to be well advanced in that disease process because they're not going to be going to get those preventative exams done to see. They're not going to get tested or screened or what's the other word that we use for secondary? We said testing, screening, and detecting. They're not going to get those exams done to see if there's a disease there because they have to come out of pocket. Just a standard blood draw can cost you $100. So when those individuals do get diagnosed, they're more likely to be advanced in that disease process because it's not going to be caught early on because they're not going to get screened or tested or detected. All right. And so they go ahead. Was that clear? Any questions about that? Oh, I thought I was here.
Because they don't have money, they wait until be like it's no solution, and then they go to the hospital because they don't have money.
Exactly. So and they put it off and put it off. It's like, okay, I gotta go now. So once they go to the hospital, they're so advanced, and so treatment options may be limited because they're so advanced. We talked about the vulnerable populations. So I will say this one. Why is a 26-year-old pregnant woman not a vulnerable population?
Because she's not a young pregnant mom.
She's not a young pregnant mom and she's not an older pregnant mom. So she's right at that age. So yes, so think about when I asked you all before we took the quiz, what is vulnerability? It's something that puts someone at risk for not so good things happening to them, for having less favorable outcomes. So we know a younger, if that age was 15 or 16, or if that age was 45 or 50, then that would be a whole different scenario than someone that's 26. But we did say chronic disease processes, HIV, hypertension, someone that's a substance abuser, because they are not making decisions as they normally would if they were not using that substance. And then our veterans, okay? And so resiliency, the ability to bounce back, the ability to figure out, well, hey, I have this problem, acknowledge it, but what can I do about it? That's resiliency, the ability to bounce back, the ability to pivot, to move forward. If someone is resilient, it decreases their chances of being vulnerable. It decreases or lessens their chances of something bad or not having so good favorable conditions or outcomes. We talked about who are we going to see first? We're going to take care of all of our patients. Someone said airway, breathing, and circulation is going to guide us toward who we should see first. Then you all gave me some examples. You said airway, breathing, and circulation. Well, what are some signs and symptoms that we might assess if someone has problems with airway, breathing, and circulation? Well, they're unable to do what they normally would do. They're having trouble talking or completing sentences. They may be coughing. So out of those children, you all know which one that we would take care of first. They're unable to participate in their activities because they're having trouble moving air. Several of you all selected the other one where the child was having some issues with their skin. But remember, airway, breathing, and circulation. So use that as your guide. Think about Maslow's hierarchy of needs. What's on that found? If airway, breathing, and circulation has been taken care of, then what do we go to next? Food, shelter. That helps us to decide the order that we take care of things. Okay. And let's see. I think the other ones, that was it. Those were the ones that were mostly missed. Are there any concepts that I didn't go over? Those were the top ones that were mostly missed. Are we good, Ms. Gonzalez? Were we good? Did I catch everything? So again, you have to know the concept. Then you have to be able to apply what you know to the scenario in order to be able to pick out and decide which intervention, what's your next steps. All right, that community-based nursing. 101, we're talking about illness care. It's tertiary. All right, so we have the levels of healthcare prevention, primary, secondary, and tertiary. Tertiary, we're trying to manage a disease process. Secondary, we're screening, we're trying to detect, we're testing. And then primary, we're just trying to prevent it altogether. Healthy People 2030, we are decreasing, we are trying to achieve health equity, eliminate. We're not just trying to decrease disparities. We're trying to just eliminate them altogether and then improve the health of everyone. We talked about the firearms. The goal was one of their goals is to decrease firearm related deaths. And out of our list, we said that it was priority for us as the nurse to find out where the firearms are actually stored. Okay. Social determinants of health they have a major impact on people's health, well-being, and quality of life. And then, well, what are these social determinants of health? They are our literacy skills. There are our language skills. In the event that my first language is German and you give me information in Spanish, am I going to be able to do anything with that? No. You prevent me from being able to take care of myself because you have not placed the information in my first language, the language that I have the ability to understand. But then make sure that the information is on my level. Now, they have these pre-printed pamphlets and these videos, and they're basically based on, I want to say, 4th or 6th grade level. So, but then even with that, sometimes people have challenges with understanding that. So just make sure that the person that that you're reinforcing that teaching for, make sure that it's on a level that they can understand. And a lot of times, once you establish that therapeutic relationship with your patients, they'll let you know that they have literacy issues, that they're unable to read, or they just don't understand. They can read it, but it just doesn't make sense to them. And we do want to go back and reinforce that teaching and put it into terms that they can understand, because it will directly impact my health, my well-being, me being able to take care of myself. If the water is polluted, if the air is polluted in the area that I live in, that directly impacts someone's health. The access to nutritious foods and physical, the ability to get up and move. We just talked about getting up and moving, being physically active. If I don't have a safe place to walk, if if there's not a good lighting, or there's not a gym that I can go to or afford to go to, then those things can directly affect my health. Safe housing, if the environment that I live in, if it's not safe in the neighborhood, if there's an increase in violence or discrimination. Now, all those are social determinants of health, and they do directly impact a person's health and well-being. We talked about vulnerability. A person's vulnerability, their resiliency affects a person's vulnerability directly. But the increased resilience decreases a person from being vulnerable, because they're able to quickly identify, I have this issue. Okay, let me identify some interventions that will help. We talked about being the school nurse. The school nurse cares for children of all ages and all different disease processes, from asthma. As a school nurse, you can do tube feedings. You may have to assist with that inhaler. You might even have to do primary prevention. They call you into the PTA meetings, the parent-teacher organization meetings. You have to provide that information on how to prevent injuries while the child is participating in a sport. As a school nurse, you may be certified to teach CPR classes. So then you teach those classes to your coaches and to your principals. But that, as a school nurse, you wear many, many, many hats. But be aware of, we do not diagnose, and we do have to we're going to take care of all of our students, but let ABCs guide who we take care of first. So I'm going to pause here because we have to take our break. As we just mentioned, the social determinants of health directly impact one's ability to manage their healthcare and live healthy from day to day. Income directly impacts a person's health outcomes. So if I'm underinsured or uninsured, that means if I want to have a procedure done, a preventative, even just to go see the doctor, I will have to pay out of pocket. So if I have low income, that increases my risk of chronic illnesses, because more than likely I'm not going to have the money to pay for those preventative exams to even see if I have a disease process. So low income, not having enough money, increases a person's risk of chronic illnesses. And we did say that that disease process is usually well advanced, because they're not going to get those preventative exams like they normally would. So that low income also equates to someone that's living just above the federally defined poverty line. So if the person makes $1 over that federally defined poverty line, then all of those community resources that they had available to them, had they not had that $1 over, or that $5 over the federally defined poverty line, what that means is they are at an increased risk of vulnerability, because they're going to have fewer resources available to them. And we just said income will directly impact someone's health. So if I have just $5 over that federally defined poverty line, then I don't qualify for those community resources. So in order for me to use those resources, I will have to pay for them. Therefore, I will have an increased vulnerability due to not having access to those community resources. As a matter of fact, I will have fewer resources available to me. So we talked about the vulnerable populations, the very young, because anyone that is under 19, so a person from 1 month old, 15 months old to 18, they solely rely on an adult or a guardian, a parent or guardian taking care of them or providing for them. So if someone is 19, if they're 21, they're 68, their health outcomes will not be as greatly affected compared to someone that is 1 month old, 12 months old, or 18 years old. Why? Because anyone that's under 18 solely rely on someone else providing for them. Okay. So that age in itself automatically, because they're less than 19. But if they're 19 and older, they're not at a higher risk as someone that is 18 and younger. So a person that we talked about the income directly having an impact on someone's health and the things that they do. So a adolescent, they have an increased risk of dropping out of school if they're living in poverty, because more than likely they might want to assist the family with some of the income. And so they're trying to work rather than focusing on their schooling and their learning. So they're at an increased risk of dropping out of school. Anyone that's impoverished, because remember, we just said income does directly impact health outcomes. Low income increases the risk of someone having chronic illnesses. It also increases the risk of someone dropping out of school. It increases their vulnerability because that person is not going to have access to community resources for those that live just above the federally defined poverty line. Okay. So the rural areas are, or either very rural areas, things are spread out. So their areas, if it's very rural, there might not even have a doctor's office. More than likely, there's not going to be a hospital there. And so if a person needs specialty care, they're going to have to travel to towns over in order to travel maybe an hour, 2 hours just to receive that specialty care. So they are more likely to have complex chronic illnesses because because that barrier of access, not having things, is not that people don't want to take care of themselves, but not having things readily available to them. That puts them at an increase. They're more likely to have complex chronic illnesses. Primary prevention, we are preventing something. We're preventing sun exposure. We're preventing heat exhaustion. We're preventing seatbelt injuries. So what do we do with primary prevention to prevent those things? We provide information. That can be a conversation. It can be a pamphlet. It can be a radio announcement. We're providing information to decrease or lessen the chance of something, whatever that something is. It could be sun exposure. It could be firearm related death, but we're providing that information. Primary prevention focus on preventing that injury, preventing that chronic disease process from ever occurring. If we're that nurse at that clinic or even at that emergency room, we do want to consider our patient's work environment. We want to consider that home environment when they come in. If the patient is complaining of, for example, eye irritation, throat irritation, cough, so we want to ask, what environment do you work on? What do you do as task on your job? because it might be related to, more than likely, the symptoms that that patient is experiencing is going to be related to something that they've been exposed to in their environment. And we do know that migrant farm workers, they use pesticides, to place on the plants to keep the plants alive, so that the pests, the little bugs and things, that they die so the plants can stay alive. So as a result of that, if we have a farm worker coming in, we want to ask, well, hey, what tasks do you complete at work? Do you use any pesticides? Because if they're coming in with eye irritation, throat irritation, and cough, they probably have been exposed to those pesticides, and they might not have had on their protective gear. So we do want to consider people's environments if they come in complaining of certain signs and symptoms. So we do know that migrant farm workers, they are coming to complete their job, and those jobs are seasonal. They only last for a couple of months. And so a lot of times at housing, there are several people that live, or several families, different families that live in the same space. And so anytime we want to consider the environment, we have patients coming in, and sometimes those living conditions in those housing that's provided, because remember, the employer, they have the workers coming in maybe 2 months a year. So those living conditions might not be up to par. So we want to consider doing tuberculosis symptom screening, that's secondary, especially if there are crowded living conditions. Even if we were working in a homeless shelter, there's several people from all different places in those conditions. Sometimes they have an account for the shelters, but those conditions are usually crowded as well. So those crowded living conditions, we want to know that more than likely we will have to provide some type of tuberculosis symptom screening questionnaire, just so that we can be proactive in preventing the spread of a communicable disease. So going to the homeless shelter, in the event that, remember, we're going to take care of all of our patients no matter what setting it's in. We're in the homeless shelter setting. We just talked about those crowded living conditions with the migrant farm workers, and also in the homeless shelter. So we do want to screen, and we want to be proactive and do those tuberculosis questionnaires. And so we do know that tuberculosis is a communicable disease, and it can spread. It's airborne. And so what signs and symptoms would a patient complain of if they have been exposed to that tuberculosis bacteria? They will complain of those night sweats. They would have that unexplained weight loss. So those are things that we need to prioritize if we have patients, if we have several people that are complaining of signs and symptoms. We want to make priority that patient that's complaining of those night sweats and unexplained weight loss, because we know in the event that if that is in fact tuberculosis, that everyone has an increased risk of that tuberculosis being spread because of those living conditions and how tuberculosis is spread. It's airborne. So everyone that's in that space has an increased risk. So that is why that patient would be priority. That's why we would want to go and take care of that patient first. We're going to take care of everyone else, but when we're trying to put things into priority, we want to consider that. And so there are certain things that put people at risk for being homeless. And we talked about those vulnerable populations. Our veterans are vulnerable populations because a lot of them, a huge number, a large population of them have that PTSD, that post-traumatic stress syndrome. And so, and anyone that does not have support, whether or not if they're living in a group home or they're living with family members, if someone is alone, they have a higher risk of being homeless, because if they have post-traumatic stress syndrome, because they will have more than likely have less survivor techniques, they will have less stress reducing techniques, and so that in itself puts them at higher risk for being homeless. because having that support from your families or others in group settings, they play an integral role in us being able to be resilient and figure out what it is that we need to do. Figuring out those interventions and what our next steps would be. Growth and development, educating new parents about safety guidelines for infants should include: do not leave an infant alone in a bathtub at any time. Never leave that infant alone on an elevated surface, such as a high chair. We do want them to cover electrical outlets and keep wires and cords out of reach of children. We want the children to dress in that child-safe sleepwear. Turn pot handles toward the back of the stove. We do want to encourage regular checkups as recommended at least every 2 years to just get that growth and development assessed to ensure that child is growing healthy. Children should be physically active for at least 30 to 60 minutes per day.